Hi, good evening, ladies and gentlemen. Thank you very much for inviting me to this valuable course, Back to Basics. I will talk in the next 20 minutes about when to start the invasive hemodynamic monitoring. So my objectives for this session is I will go very quickly to a definition of shock, why we need the hemodynamic monitoring. These are four questions that you can ask yourself before starting any monitoring. What to start to monitor the patient, when to start, and what's the evidence base behind the hemodynamic monitoring, and finally, take a home message. Shock is not a disease, it's not a single entity, it's a form of generalized failure of the circulations, which ends with poor perfusion to the tissue, poor oxygen supply and utilization by the cells, and finally, it will end with the cellular dysfunctions. So shock can affect all the organs, specifically the vital organs. So why we need the hemodynamic monitoring? So if with the clinical and history, I cannot identify the type of shock very clear, so I need the hemodynamic monitoring to know what's the type of shock. I need also the monitoring to select the appropriate interventions. For example, if is this patient candidate for vasopressors, for fluids, for pericarditis, etc., etc. And also I need to test and to know what's the patient's response to my interventions, and I want to do it in a frequent manner. So what we can get from the hemodynamic monitoring, simply we can get the cardiac output, which is very important to differentiate is the patient's in a shock status with high cardiac outputs or low cardiac outputs. We need to know the fluid responsiveness of the patient. It's a very important topic and very important task for the hemodynamic monitoring. Is my patient will get a benefit from the fluids or not? Because hypovolemia and hypervolemia, both of them are harmful. And just to mention, the fluid responsive is defined as, or the definition of the fluid responsive is improvements in the cardiac output and stroke volume at least 10 to 15% with a fluid challenge. I need to know what's the tissue perfusion and if my perfusion to the tissues is improving with the interventions or not. And I need to know the picture of the idea about the vascular tone. Is the patient is vasodilated in distributive shock or vasoconstricted in a cardiogenic shock? So what to ask myself before starting any hemodynamic monitoring? There should be a clinical question before starting hemodynamic monitoring. So if the clinical data and also the history and the patient status is already, I know what's the underlying cause of the shock and I can't treat. So this is not a clinical question. You should have a clinical question. For example, if I don't know what's the fluid status of the patients, if I don't know what's the clear cause of shock. So this is the questions which can push me to start some invasive or non-invasive monitoring. I should start with non-invasive or minimally invasive first, and then before jumping to the more invasive one. I should also check if I'm competent enough to insert the catheter, if I'm competent enough to read the measures and deal with the measures and numbers or not. Do we have a trained staff, especially nurse in charge and well-trained nurses over the night shift? It's very important before starting some invasive monitoring. The cost of device also is important task in some hospitals. So what to start? So there's a spectrum of hemodynamic monitoring, starting from the gold standard, which is the pulmonary artery catheter. Actually, the trend is going down for using of the pulmonary catheter. So non-invasive is quite simple, quite available. Yeah, we are talking about the transthoracic / transesophageal echo. And then there's in the middle, the minimally invasive, which can start with simple central venous catheter going to the arterial line, and some non-invasive monitors or minimally invasive monitors like BICO, LITCO, or Vigilio, and ends with the esophageal Doppler, which is usually the use of esophageal Doppler is usually in the theater and intraoperatively. So the gold standard of all the hemodynamics monitors is the pulmonary artery catheter or the Swangans. I think the trend is coming down, especially after famous trial RCT's Pacman trial. They conclude in this trial that there is no effect on the mortality or there is no effect on the survival in comparison of the pulmonary artery catheter group and the control group. And there is another interesting review, 2018. The question is there still place for a Swangans catheter? The answer was yes, but in a very specific situations. So if you want and you cannot able to diagnose the right ventricular function, especially with the ARDS and septic shock patients, so this is the time that you may need the Swangans. It's the only way that it can, the only thing or the only intervention can differentiate between the pre and post capillary pulmonary hypertension. If you want to know what's the effect of the ventilator settings on the right ventricular functions, you may use the Swangans. And if you are in a patient in a severely critically ill patients, complex clinical situations with the refractory mixed shock, and especially if the patient is also associated, the condition associated with the ARDS. So interestingly, in the same journal, in the same year, and published also on the same date, with the same title, is there still a place for Swangans? And the answer was no. And the conclusion, this is a very nice table. They said that all the clinical problems or the clinical questions that you can get from the Swangans, you can have alternative methods, which is less invasive, like echo, like non-invasive or minimally invasive monitors, or clinical, which is can give or can answer all these questions instead of the Swangans. And even they said in a nice paragraph that the place or of the Swangans now is the medicine museum, is not the clinical situations. So talking about this very simple, minimally invasive arterial line, it's not only for the measurements of the blood pressure, but you can get a lot of data, a lot of information from the arterial line. For example, for the systolic pressure, which can give you indicate about the LV afterload. Diastolic pressure give you a picture or idea about the arterial tone. The MAP pressure, which is the organ perfusion pressure, you will know about what's the target you want to achieve. Pulse pressure give you idea about the stroke volume. For example, wide pulse pressure is associated with the distributive shock, hyperdynamic shock. Narrow pulse pressure is the cardiogenic shock. You can also adjust your monitor to measure the pulse pressure variation, which is a very good indicator of the fluid responsiveness. You can take samples and you can send also EBG. So what about the central venous catheter? Central venous catheter was used for decades to indicate or to get about the pressure, the cardiac filling pressure, and especially on the right side, and to use this number to guide the fluid management of the patients. It's a very nice research article by Dr. Osman, and for the top part of the paragraph, you can see that the central venous pressure numbers starting from 2 up to 16 for both responsive and non-responsive patients, there are no big difference between the patients who are responded or the patient who does not respond to the fluid management with these variable number or very wide number of central venous pressure number. And even they said that if you depend on the central venous, a single central venous pressure number to guide the fluid management, it's a matter of coin flipping. You can see even that there is still a few patients with a CVB of 0 or 2 who are non-responding to the fluids. And there's a few patients with a CVB of 16 who are still responsive to the fluids. The same also findings they found about the pulmonary wedge pressure or pulmonary artery occlusion pressure. So more than 100 studies have been published in the last 10-15 years, trying to demonstrate in relation between the CVB or even change in the CVB and fluid responsive. And the CVB measurements are no longer required to guide the fluid management in ICU. Minimally invasive, it was very interesting topic from Dr. Susanna Price about the minimally and non-invasive hemodynamics. I will just mention here one slide, secondary analysis of Andromeda shock trial 2020. And I will just mention that in this secondary analysis, they found that around 80% of the patients, from 80% of the patients, you can know, or you may know the fluid responsiveness of about 80% of the patients from the minimally or non-invasive parameters. So when to start, I think this is the most important slide in my lecture. So if you are encountered with acute circulatory failure, take a good history, do a proper clinical examination, especially including the CRT, check the lactate, start with echocardiography, scan the patient to find answers for the cardiac output and fluid responsiveness. And then if the picture is not clear, or if the patient is not responding to your initial therapy, you can start with arterial line and central venous line. You will get a lot of the information from those catheters. If still the picture is not clear, or the patient is not responding very well to your initial management, or the patient is known or diagnosed with a severe ARDS, so this is the time of starting some hemodynamic monitoring. If you want to start something, start with non-invasive or mini-invasive. If you cannot get the answer, or you are in a complex situations, or your patient is diagnosed with the RV dysfunctions or pulmonary hypertension, then you may use the pulmonary artery catheter. So what's some evidence-based? It's a very nice consensus from the European Society of Cardiology 2014. So they recommend frequent measurements of vital signs, and in addition to the clinical findings and history from the patients who presented with shock. And they recommend also that you should not use a single variable for the diagnosis or even for the management of shock. It's very important also, recommendations, don't rely on the blood pressure to diagnose the shock. So you can see a shock patient with who is normally high, with a normal blood pressure or even high blood pressure. They recommend using the blood lactates, and they put a figure of 2, more than 2, to diagnose or to say that the lactate is high in the shock patients. They recommend also that to use the hemodynamic monitoring and assessment if the clinical examination does not lead to the clear diagnosis. And then you can start first with the echocardiography, and I'm sure more than 90 to 90% of the questions will be answered from echocardiography. And then if you did not get a response, so at that time, you may go to the further interventions like arterial line or central venous catheter. It's very important to check the volume status and fluid responsiveness of the patients. And they said also static measurements, static preload measurements like CVP or pulmonary artery wedge pressure should not be used to guide the fluid resuscitation. Don't rely on a single hemodynamic variable, and they recommend dynamic over static parameters for fluid responsiveness. And we will have a very nice topic tomorrow about the dynamic and the static measurements of the fluid responsiveness. Both hypovolemia and hypervolemia are harmful. It's very important to know the volume status of the patients. It's not routine to start the cardiac output for all the patients, only if the patient is not showing a good response to your initial therapy, and start with the less invasive devices and then reevaluate again. It's also not routine to use the pulmonary catheter It may restrict it to the patients with the refractory shock and right ventricular dysfunctions. And also, if your patient is diagnosed with ARDS. And from the Surviving Sepsis Campaign 2021 for the guidelines of sepsis and septic shock, they recommend also the invasive monitoring of the arterial blood pressure, although it's a weak recommendation. And they recommend to use the dynamic measurements to assess the fluid status over than the static measurements. 2017 from European Society of Cardiology guidelines for STEMI. So they give a class 1C for invasive blood pressure monitoring using the arterial line, and they give 2B for using the pulmonary artery catheter. So take a home message, start with the clinical, do intervention, start with the clinical again. So examination, intervention, reassessment, intervention, and reassessment. So the clinical and reassessment is very important. You should know what's the cause of shock, and is it a single type of shock, for example, cardiogenic sepsis alone, or it's a mixed type or a mixed shock because the treatment will not be the same. If the patient showed initial positive response, so rethink about the need for the hemodynamic monitoring. You can start with arterial line, central venous line. The echo is very important, and I think the next topic with Dr. Hatem Sulaiman will be very interesting about the role of echo in hemodynamic monitoring. Start with non-invasive and minimally invasive. Consider the presence of trained staff, especially the nurses over the night. Don't treat a single number, it's the whole picture. Thank you very much, and I'm very happy to accept any questions. Thank you.